Welcome everyone, good evening. Welcome to this Facebook Live from Crohn's and Colitis UK. It's fantastic to be able to host this, and we hope it's going to be a really useful and interesting session for everyone. So we'll just start with some introductions from the panel. My name's Ruth, I'm one of the directors at Crohn's and Colitis UK. And I'm delighted that we're co-chairing tonight with Louise. So I'll let Louise introduce herself.
Hi, I am Louise. I am the one of the charity's research champions, and I'm also an online blogger and patient advocate for IBD. And it's lovely to be here.
That's fantastic. Thanks, Louise. And we've got three gastroenterologists as well who have joined us tonight. So I'll go to Charlie first for introductions.
Thanks, Ruth. Thanks, Louise. Thanks for having us here tonight. It's really great to be here. My name is Charlie Lees. I'm a gastroenterologist here in, I would say, sunny Edinburgh. It's filthy weather. The dreek day, as they say in Scotland, in Edinburgh. So I'm a gastroenterologist here. I'm working also at the University of Edinburgh.
That's great. Thank you, Charlie. It's great to have you with us. And I'll ask Elsa next to introduce herself.
Thanks very much, Ruth, and welcome everyone who's listening. Great that you're all with us this evening. So my name is Elsa Hart. I'm a consultant gastroenterologist in London.
And Tim, it'd be great if you could introduce yourself.
Hi, thanks Ruth. Thanks for the invitation. My name is Tim Rain. I'm a gastroenterologist based in Cambridge, and it's a real pleasure to be with everyone here this evening.
Thank you. So we're really grateful that you've joined us this evening. So this event is for everyone affected by Crohn's and colitis. So you might have the conditions yourself, or you may be caring with or living with someone with the conditions. And so the challenges that these conditions bring can impact any of us, and this session is for everyone. So it's an opportunity tonight to share experience and suggestions. Everyone is different, and what works for one person may not work for others. So we won't be giving specific medical advice, but we will mention resources as we go along that you might find helpful. And we'll be posting links up in the comments section as we go along, so you can seek support if you find things difficult. So we're here to answer the questions that people have put on the Crohn's and Colitis UK Facebook page in advance, and also questions that you're posting up tonight. We probably won't be able to answer every question, but we will certainly do our best. And we ask that you're respectful to everyone attending when you post comments and questions in the chat. So I'm going to hand over to Charlie, Elsa and Tim at this point, who are just going to set the scene a bit for us and tell us a bit about new treatments.
Thanks, Ruth. Thanks again to everyone. What we're going to do for the first 5 or 10 minutes is just do a little bit of scene setting, just to orientate you to the problem that we see as gastroenterologists. It's great that Louise is here to give the patient perspective, the sort of Crohn's Colitis UK champions perspective too, because of course that is the most important piece to us. Just before we start, Tim, Elsa and I are gastroenterologists, we are clinicians. We also at time points work with people in industry, in pharmaceutical industry, under consultancy agreements to help really further the development of the therapeutics that we have available to us, and to help bring them to the clinic. So it is only fair and transparent that we present to you our disclosures on that point, but this is a totally independent meeting tonight, and we are speaking purely from our own opinion and our own accord. So Crohn's and colitis affect now nearly 1 in 100 people in the UK. It's quite extraordinary, the numbers. We still don't really understand all of the causes. We really recognize there's a dysregulated mucosal immune system. The microbiome is clearly altered, this observed dysbiosis. And there seem to be very clear environmental and genetic drivers, although we haven't unpacked all of that yet. We are, through learning more and more about the disease biology, including the genetics, getting more and more druggable areas, more drug targets, more specific therapies, and that's quite a bit about what we're going to talk tonight. We are very aware as clinicians that Crohn's disease and ulcerative colitis are highly unpredictable. We recognize very much that, unfortunately, there tends to be a progression over time in at least a proportion of individuals. That means that most, but not all patients need some form of medical therapy, not just to induce remission, but to maintain remission over a time period, to prevent the disease from flaring, hopefully, to keep people out of hospital with disease flares if possible, to try and prevent the need for surgical intervention, to try and prevent the complications also of our drugs. Surgery is not a failure of medical therapy. It's often a very proactive and a positive choice for patients. Probably not going to talk about surgery too much today, rather around the medical options. We certainly recognize there are many unanswered questions, everything from why do people get IBD, why is it getting more common, to what drives some of the drug response, non-response and treatment progression, and some of these things we will touch on today. But I think we are very aware of the really fairly urgent unmet need in the clinic, and that's why we are working along with our partners in industry as clinicians, with many of us also with an academic hat on, and it's great to also be partnering with Crohn's and Colitis UK to help move things forwards. Tim put together this wonderful schematic in a very nice review paper that's it just come out in Gastroenterology, trying to think about how we can properly advance care in IBD. We have described this therapeutic ceiling. It sits, as you can see on this chart here, at about 30 to 40%, which means what? It means that roughly, with most of the drugs that we have been using to treat Crohn's and colitis, that we are getting somewhere between 30 to 40% of people really pretty well by a year without the need for steroids. But we have struggled a bit to really break through to get to the point where we're getting 60, 70, 80, 90+% of people properly well without side effects from treatment. And that's driving us to help move things forwards. So there's quite a lot of bits to this. Some of it's around getting people onto drug therapy early, with an early diagnosis. Some of it will be about better risk stratification, predicting outcomes. Some of it will just be about improving how we deliver care to patients and making systemic improvements. And Crohn's and Colitis UK have been fantastic from all of that point of view. Some of it's a bit more technical in terms of drugs, drug combinations, drug monitoring, around the clinical trial design to make sure that we're making the most of what we're doing. Developing new therapies and bringing them to the clinic is expensive, and that's why it's important that this really, as much as possible, is joined up. We will, I think, come to this later on, but the crux of what Tim, Ailsa and I do in the clinic day in, day out, in conversation with our patients, is to try and get the right drug, or even the right drug combination, into the right patient at the right time. And that sounds very simple, but sometimes it's really very challenging. And sometimes we just have to work with our best sort of guesstimate based on all of the observed things that we have there to try and make that happen. So precision medicine is where we might do this based targeted on a biopsy. We have a number of different clinical trials that are helping to inform this. And we're going to talk today a little bit probably about drug sequencing, the role of biosimilars, antibodies versus some of the new small molecules, and perhaps touch on our hope for combination of therapies. Now, in a moment, I'm going to hand over to Tim, and Tim's going to talk us through where some of the new drugs are in terms of the bits of the inflammation process within the gut, within the body, that they are targeting. This, for you here on your screens now, is a timeline to try and orientate to where things are going. And the big thing I want you to take away from this is that there is a lot happening. This timeline is not quite to scale. This is a timeline of advanced therapies, and by advanced therapies we talk about biologics as well as some of the newer small molecules. So we're not here talking about azathioprine or methotrexate or mesalazines. So we've had the anti-TNF therapies with infliximab and adalimumab for now 25 years, 20 to 25 years. That's a long period of use. And we're still using these drugs a lot. And now on the bottom, we have these drugs available to us as biosimilar drugs, which has meant that the cost has come down very, very substantially. And I'm sure we'll pick up the advantages of that later on. But this has been something we've been strong proponents of. We've been able to offer anti-TNF therapy at a fraction of the cost from previously. That's enabled us to treat a wider range of people at the doses and at the time points that I think are making a big difference. We then, if you look at the middle, on the top in the red, you've got vedolizumab, and I think Louise might speak briefly to her experience here. I think Louise was one of the first patients to go on to vedolizumab across the UK. We've got some patients now in Edinburgh who've been on vedolizumab for coming up to 8 years. And who've done very well from that point of view. So Tim is going to orientate you to what these drugs do. I'll just give you some of their names. Vedolizumab is now available as an injectable form, a subcutaneous pen or syringe. So that's been a significant step forward from that therapy over the last couple of years. That came in about the middle of 2020. So vedolizumab for Crohn's disease and ulcerative colitis. Then underneath that in the middle, you've got ustekinumab, which is an IV induction and then a subcut maintenance drug, which came in for Crohn's disease already now 5 or 6 years ago, and for ulcerative colitis a bit more recently, about 2 or 3 years ago. And then even in the middle there, it's getting quite crowded already, you'll see, we've got tofacitinib, and tofacitinib is an orally acting drug. It's the only of the advanced therapies that we're currently using in the clinic that's available in tablet form, and that's just for ulcerative colitis. And then you cut forwards to 2021, 2022 here, where we've now got ozanimod coming, having been approved in the US and coming imminently in the UK, and filgotinib, which is, as Tim will explain shortly, another of these small molecules that's targeting the JAK pathway. So there's a lot happening in quite a short period of time. And then this bit at the end that says late stage development has another 6 molecules listed on it. And although we're not going to get too worried about specific timelines today, we'll try and give some broad brushstrokes around that. These are all molecules that we're hoping we will actually see come to the clinic in some point in the next 1 to 2 to 3 years. So there is a lot happening, and this is good news, I think, for me, Tim and Elsa as clinicians, and I think that also means really good news for our patients. So I'm going to hand over now to Tim, and Tim is going to dive a little bit more technically, but just to try and flesh this out as to where these drugs actually are working within the body. Tim.
Thanks, Charlie. So good evening, everyone. And I don't want to spend too long on this slide because it's frankly horrific. This is an attempt to kind of represent something of what's going on in the inflamed gut. So just to orientate you, at the top there, you've got the lining of the bowel. That's where food and fecal matter passes. You've got a layer of cells that's actually really important. It's an epithelial layer. That's the barrier between us and the outside world. And then underneath that epithelial layer, you've got some immune cells represented. And it's really these immune cells that both police the bowel and keep us healthy, fight off infections, but also in the case of people with active inflammation, it's these same immune cells that cause problems and where some of the trouble originates from. And so it's these cells that form the targets of our current therapies. I stress current therapies because very often a question that comes up is, why is it all about suppressing the immune system? And of course, the truth is that it's really nice to also reflect upon the fact that I think there's another generation of potential treatments coming through, looking at that lining, what's going on in the gut itself and ways we can modify the bugs living in the gut, either through diet or through ways of directly manipulating the bugs living in the gut. But those treatments are a little bit further off there. They're very active and interesting areas of research. And at the moment, all the drugs that Charlie just mentioned are very much focused on the cells of the immune system that are represented in the bottom half of the figure there. Now, increasingly, what we're looking to do is to block off and shut down specific bad players without overall suppressing the immune system, without causing side effects, without hitting things that we don't want to hit. So you can see some different players there. And I'm not going to spend any huge time on any one of these, but I just want to orientate you to 4 different groups of actors here that taken together represent our developing drug targets. So on the next slide, you'll see we're going to drill in a little bit on some of the T cells. These are some of the white blood cells that live within the gut. And in particular, we now know that there's a group of T cells that live and thrive off a molecule called IL-23. And IL-23 generally appears to be a bad player in the gut. There's not a lot of evidence for it doing anything terribly helpful in a state of health, but it's definitely a key inflammatory player. And so one of those big groups of drugs in development that Charlie mentioned, molecules, monoclonal antibodies, so a similar kind of drug to the type of drug that we talk about with anti-TNF, but not hitting TNF, hitting IL-23. So you'll hear people talk about anti-IL-23s, anti-P19s, people sometimes call this class. These are drugs very specifically targeting IL-23, and we can chat a bit about those in a minute. The next group of drugs in development are actually hitting not molecules floating around in the gut or outside the cells, but actually working inside the cells themselves, working downstream of some of the cell surface receptors that pick up that signal, that tell the cells when IL-23, when TNF, when IL-6, some of these other molecules pick up that signal and transmit it inside the cell. And these messenger molecules are called Janus kinases, or JAKs for short. And you've already heard Charlie mention tofacitinib. That's an inhibitor of JAKs. It shuts off or reduces signaling through JAKs. And some of the most active areas and some of the most promising treatments coming through now in both Crohn's and UC are drugs, so-called small molecules that penetrate inside the cell and block signaling either through all JAKs or through specific members of the JAK family. So you'll hear people talk about drugs such as filgotinib, upadacitinib. These are inhibitors of Janus kinases or JAKs, and they help shut down this sort of signaling. The next group of drugs are already in clinical practice, and these are drugs that block the white blood cells from getting into the gut in the first place, and they interfere with so-called integrins. These are molecules that help white blood cells stick to blood vessel walls and get out of the blood vessel into the tissue. So vedolizumab is a blocker of one particular integrin, but there's a group of drugs in development at various stages that in different ways all interfere with this signaling between the white blood cell and the integrin, and they stop or reduce the infiltration of white blood cells into the gut in the first place. And then lastly, a group of molecules coming through that affect, actually a little bit further upstream, and they affect the ability of white blood cells to even get out of the lymphatics. So the lymphatics are the home of the white blood cells, where white blood cells sit and generally hang out when they're not causing trouble in the tissue. And in order to get out of the lymphatics, one of the first things that white blood cells do is pick up a signal coming through a group of drugs, coming through a group of molecules called S1P. So this is a lipid, a fatty molecule. And T cells in particular listen out for signals, detect, sniff out S1P and go hunting after it because that's their signal to go. And there's a group of drugs that modulate the ability of white blood cells to detect S1P, and these are called S1P receptor modulators. And the examples that you saw on Charlie's slide a moment ago, Ozanimod, now licensed in parts of the world, and etrasimod in late-stage development. So these are molecules that, again, appear to have an important role in affecting cellular trafficking. So that's the scene of some of the drugs we're going to be discussing this evening, and that's very much where we're up to, and we can dig into more of these as much or as little as you want. I'm going to hand over to Elsa, who's going to tell us the really important bit, which is how we actually put all of this into practice and what we're really trying to do.
Thanks very much indeed, Tim. A great overview. And I think just to reassure those of you listening, it is bamboozling. I think we all, Charlie, Tim and I, do find mucosal immunology quite bamboozling. So please don't be frightened by it. The really good news is there are lots more possibilities here. But just to take a step back for a moment and think about what we're aiming to achieve. So this is the goals of therapy. And I think, honestly, this is where there's been a step change over the recent years. So a few years ago, there was an initiative called Stride 1, and that really tried to help us think about goals in a slightly different way. Because, of course, the goal is that we want people to be better. We want people to feel better clinically. But this initiative called Stride 1 wanted to make the disease be better, so the actual inflammation to be better. So they put a target there of endoscopic healing, or getting the endoscopic appearance to look better. But what we're showing you on this particular slide here is Stride 2, which is the more recent and updated version, if you like, of goals of therapy, and trying to really try and raise the bar with what we're trying to achieve. And I think if you work from the left hand side of this slide over, it's very much, as Charlie said earlier, if you've got active inflammation, getting the therapy according to the risk. So trying to work out who actually isn't going to have too bad a course of disease, because of course some people don't need a lot of the therapies that Charlie and Tim have just talked about. It can be a much lesser sort of therapy. But for those who do, because there is risk there, then it's getting them onto the right therapy, as Charlie said, trying to get the right one at the right time. And then this timeline is really helpful, because to me, the key word in IBD management is monitoring. As long as disease is being monitored, then I think there's the chance that we're just trying to be on top of it and not letting it run away. So symptomatic response, exactly as we've always thought, we want you to feel better with the therapies we're using. And then if you go along the timeline, this word remission, symptomatic remission, and then some of the blood markers that we talk about a lot, like the C-reactive protein or the CRP being back to the normal level, a good signal that we're on the right track with what we're doing. Then a little bit further down the line, some of the poo tests that we get you to do, which are really boring tests to do. You've got the blue top pot and off you go with it, and it's a real nuisance to do, but a really good feedback to let you know if we think we're actually putting a lid on the inflammation and getting things under control. So getting that poo test to a level, again, which is showing that things are under control. Another thing just to mention, and this is really important for younger people, particularly children with inflammatory bowel disease and particularly Crohn's disease, is getting patients to grow properly, because of course this can be a big problem in the younger people who have Crohn's disease. And then at the right-hand side of this slide, you can see this concept of endoscopic healing. So we really want the disease to be looking better when we look in with our scopes, potentially with our scans as well, because that shows the disease, the actual disease is getting better as well. But the words at the end of that final bubble are probably the most important words on this slide, and that's normalized quality of life and absence of disability, or actually just ability to have wellness is another way of looking at it. So I think these targets are really important. And one other thing just to say about goals and targets is there can be a really difficult dissociation sometimes between symptoms on the one hand and inflammation on the other. So for example, if you've got active inflammatory bowel disease, you might have lots of symptoms and all the bloods are showing that, and the stool test is showing that, and then we treat it. But there can be circumstances where there are lots of symptoms, but the bloods and the poo tests don't show that inflammation. Then it's really important that we don't start using the drugs that Charlie and Tim have shown you, because actually that isn't the target. The target is really important. It's there and we need to get it sorted out, but it might be the wrong thing to be just going on to another drug, which has got benefits, but it's also got risks as well. So this dissociation between symptoms and inflammation is really important. And that's why sometimes your doctor will ask you to have that extra test, the blood test, the poo test, the scope or the scan, to really get that understanding about what's going on. And then next slide, please, Charlie, the final one before we get the questions. And this again, just I think makes the point that the bottom part of this diagram is very much what Charlie said right at the beginning, trying to get the diagnosis as quickly as possible so we stay ahead of the curve. And there's a lot of work still to be done on that. And Crohn's Colitis UK does a great job at trying to raise awareness about the symptoms and get the diagnosis as quickly as possible. But then this cycle of getting the right treatment, this word monitoring is really important. But the top part of this diagram points to the other side of things, which I think is often slightly neglected, and I think needs a lot more of the light shone on it. And that is diagnosing the other issues which dealing with a chronic disease leads to. So the whole concept of coping, of wellness, of psychosocial issues, recognizing those is also really important, and maybe in exactly that same way that we try and recognize them and then assess them, monitor them, adjust the treatment. I think only when we get all of these things coming together are we going to try and really get that goal that we're talking about of making people feel properly better. So with that, Charlie, Tim, thanks very much for your opening slides. And I think, Louise, we're going to hand over to you for the questions. Thanks very much.
Thank you, guys, for all of those lovely slides. They were really, really informative. I was sitting here nodding, as you probably could see, in agreement with quite a lot of those ideas. But let's get into some questions that we've had prior to the live. So the first one I'm going to go into is, in what sort of circumstances would any of these new treatments be offered to? Would you have had to exhaust all of the other options before being offered to this, or is it a little bit more personalised at this stage? Charlie?
So the answer to that is a bit of both, actually, Louise, and it depends. So quite often what happens is that new therapies become available, first of all, to people who have failed and exhausted other existing therapies. Sometimes that comes about through schemes like compassionate access use schemes that come ahead of a formal approval. So there are some examples of that at the moment. I think you know one specific example. There's one of the P19 molecules that we talked about, that Tim talked about, one of these anti-IL-23 therapies called Riskbenefit, which is available for some individuals with Crohn's disease who have failed every other therapy. And that's a sort of ahead of the official approvals scheme. And when these new therapies then come formally approved to the clinic, initially often they do come slightly for those people who have failed everything else. But that's not always the case, and I think we will see this. The answer will be yes for what some of the molecules when they come through, and no for some of the others. And then over time, we as clinicians will work out where they fit best. And also, different drugs come at different prices, and that's really important too for us as as healthcare groups and as a society and organisation to be cost sensitive and to work out who's going to benefit most from which of the drugs at which time point. So the answer is yes, there will be often some restrictions in terms of who's accessible for whom. Some of that's very appropriate and very sensible. Some of that perhaps is slightly more cost driven, but these things do change over time.
I think just, Louise, to add to what Charlie said there, it's always making sure we're addressing the right issue. Because, for example, if there's a stricture in Crohn's, that might not be the right thing for a medical therapy. It might need a different therapy, like an endoscopic stretch or an operation even. So it's always just making sure it's not just going, I think almost the danger we've got is our menu, if you like, gets longer with all of these drugs, that you can jump around a bit too much without really making sure you understand what is the driver. What is the target? Is it a medical target? In which case, exactly as Charlie said, the right thing is to get the next best medical therapy. But if it's not, then make sure that we're not just using some of the medical therapies without maybe doing that well-timed operation or whatever it is. And I'd be a complete proponent, as Charlie said right at the beginning, that surgery is not a failure of medical therapy. It's an incredibly good option when it's the right thing at the right time.
Yeah, I definitely agree with your sentiment there. Surgery, for me in particular, has been completely life-changing. So I definitely do understand, the right thing at the right time. So I've had a question from the live comments. How varied is access to treatment in the UK? So do teaching hospitals have better treatments available? Tim, how do you feel about one?
No, I think the UK actually is a pretty level playing field when it comes to healthcare. And I think that's something we can be pretty proud of. When the Scottish Medicine Consortium or when NICE take a view on a treatment becoming available, that then has statutory weight, and the payers are local payers are effectively obliged to put that into practice within 90 days, in theory. Where we do see a bit of discrepancy is around the local interpretation of some of those rules and the confidence of some clinicians to get on and use treatments or to engage with payers. By payers in England, at least I'm talking about clinical commissioning groups, the ability and the willingness to kind of have some of those nitty-gritty conversations about exactly who will have access to treatments. And there is a little bit of disparity, particularly around new treatments there. So one of the things, Elsa, Charlie and myself all work in quite large teaching hospitals. One thing I know all three of us do is engage quite actively with local clinicians working in other centres to kind of support them in that exercise, in building that confidence, in building that relationship, so that if they think a new treatment is appropriate for their patient, they have access to that. So I think the message is a pretty optimistic one, actually, in that effectively patients who need treatments in the UK can and should have access to them.
Yeah, and these disparities are there, and we work really hard to try and fix them. I know Crohn's and Colitis UK work really hard with the IBD standards and other initiatives to really try and address all of this. It's why the three of us are here, trying to make people aware and raise standards, help patients or people living with Crohn's disease and ulcerative colitis be their own best advocates as well too. I mean, I think that all of this can really help to drive things forwards. But yeah, the rules across the UK, as Tim says, do mean that actually it is fairly level overall.
Great, thank you. So another question I've had is, do these particular drugs that are specific within the gut, do they have fewer side effects than the older drugs such as like infliximab or azathioprine? I will open that up to anyone who wants to answer.
So I think all of the drugs have got risks and benefits. I think broadly speaking, all of the drugs that we're using to treat inflammation in the gut carry with them risk of infections. That's probably the biggest risk of all of them. The gut selective ones, they are low risk, but they're not no risk. I think often if there are other issues or medical problems, we call them comorbidities, then sometimes we would lean towards something like one of the specific gut ones because of that lower risk profile. But I think that the other thing to say very clearly is that all of the drugs are low risk. I think when we talk about drugs, we often talk as the gastroenterologists, and maybe wrongly actually, about risks and with less emphasis on the good that they do. So it's super duper important that everyone really does understand the risk, and that's why they're all directed to the patient information sheet to read the detail of it. But I think sometimes there might be a little mistake that we don't say enough about the good things that these drugs do. So they are all low risk. And I think probably the gut selective ones are probably the lower risk of the ones that we've got. But Tim and Charlie, do chip in with your thoughts there.
Yeah, can I come in there? I mean, I think one of the processes we go through when we're using new medications is to think about precisely this question around safety. And there's a bit of a paradox, right, which is that clearly the longer a drug has been around, the more patients it's been used in, the better our understanding of the safety profile will be. So we can say with really, really very high degree of confidence exactly what the risk of, for example, let's take a really bad outcome like cancer. We can say with quite a high degree of confidence what the risk of cancer for a patient prescribed azathioprine is. It gets really, really hard to say that because cancer is thankfully incredibly rare as a consequence of drug treatment. So it's quite hard to say anything definitive about cancer for a new medication. So we then have this quite difficult conversation. Because do we say to a patient, well, actually, we don't know the cancer risks, which is to frame things a bit negatively, or do we say, actually, there's a very high degree of evidence from scientific studies, from all sorts of toxicology studies that have been done that suggest this is actually a really safe drug. And so this comes down to a very personalized discussion. To what extent does a patient want is a patient very risk averse? Does the patient want to know a lot about risk profile, or do they want a new treatment where there's a lot of hope and a lot of promise? But as Elsa says, I think we're slightly the victims of our own success here. These drugs that are already so safe, that looking to improve upon the safety of an already very safe group of drugs is a really sort of nice problem to have in a way.
Yeah, I think I agree with all of that. I would just add to this that we talk about risk-benefit analysis when we're thinking about a drug. And sometimes it's as simple as the risks of treating and actually maybe the risks of not treating. So Crohn's disease and ulcerative colitis, as many people listening in today will know, can be really, really nasty. And that inflammation that is there within the gut and the body can be very damaging. And so the risks of not treating often far outweigh any of the risks with our therapies. And so to me, the conversation joined up together between us and very often with the fantastic help from our specialist nurses and increasingly from our pharmacists, in partnership with an individual patient, we can try and generate this sort of risk-benefit framework, which is it riskier to treat or to not treat? And very often the question is, it's riskier not to treat. And then it's what's the best therapy with combinations of the mode of action and the mechanism of action, as well as the risk profile.
Louise, before we go on, can I turn that question back on you? Because if you don't mind sharing your personal view of this, because you sat there, you received a treatment that no one in the UK had ever had before, right? So how did that risk conversation go, and what was going through your head?
That's a very, very good question. So I was started on vedolizumab back in 2015, so it had not been around very, very long. My consultant gastroenterologist was sitting waiting for NICE approval because I had failed everything else. So for me as a patient, I was really apprehensive about not being on medication. I think for me, it was that whole process of, I don't want to be in a flare-up. I don't want to be hospitalized because I'm that unwell. So I took the risk of trying a new treatment, and we always had a backup plan. And we always had a very long and lengthy discussion about my options, and they did include surgery. So I had a lot of information thrown at me very, very quickly because it was brand new. But I always had a really good team behind me, monitoring me, supporting me. You know, I had the full support of not only my medical team, but probably my own support team at home as well. So for me, the risk wasn't too high. I thought it was worth the gamble. But I am one of those patients who isn't risk averse. I will go for it. So yeah, I hope that answers the question. But yeah,
I think you're absolutely right, Louise, to say it's so personal. Risk and perception of risk is so personal. It's impossible, I think, to generalize. I think the more people I talk to about drugs, the more I realize that personalized medicine is personalized because it is directly for the person sitting with me at that moment in time, actually.
Yes. Yeah.
Vedolizumab was an interesting drug, wasn't it? Because it was really developed for the gut. So we didn't have the experience. We just add that some of these quite a few of the new therapies, we have the advantage of working closely with our colleagues in dermatology and rheumatology who've already been using some of these drugs. So often there is already quite a wealth of experience, which helps with that conversation.
Yeah. So I've had a lovely question from the Facebook Live comments. So with the new treatments that are coming, should patients be postponing surgery as these medicines may be, a different option for them? How would you respond to that question?
A really good question. Probably you'll be unsurprised to say it depends a bit on the circumstance here. But if we take, say, colitis, ulcerative colitis, I think again, surgery is always an option for people with ulcerative colitis at various different points along the pathway. And I think there's a very individual tipping point. So for some people, they really need to feel in their heart of hearts their disease has had access to every single therapy that we have available, and only then would they feel comfortable, life with no regrets, that surgery is the right thing, and then they would deal with the outcome to surgery, whatever they might be. For other people, actually, that tipping point is much sooner. And they actually get fed up with a feeling unwell and grotty and side effects or not of drugs or just all the monitoring and everything else that having colitis, which can be grumbling, can do. And for those people, it might be a little bit sooner. So I think it is, again, quite a personal thing about tipping points, actually. And I think, again, maybe a danger that we face with this ever-increasing list of drugs, because when these new drugs do become available, we're probably going to be offering them to people who've had a few of the biologic drugs anyway. So their disease is already declaring, if you like, that it's not great disease. And then what we would hate to see is that particular person having another difficult X months, whatever that is, losing a bit of quality of life or normalizing poor quality of life without well-timed surgery. So I think it's to do with personal tipping points. And I think, you can always have the view of, might be something better tomorrow, the manana sort of attitude to life. But my counsel to patients, I think, would be a little bit to sort of try and make the decision based on the moment in time without always thinking, well, there might be something available, because there are other options, which can be jolly good options for some people.
I agree with that completely, Elsa. I would just add to that I would definitely not postpone a conversation with a surgeon if that is what is being planned, and then you can discuss it with them. And I would also very much discuss this specific point, if it's relevant to you, with your gastroenterologist. To me, the reality of the situation is often, from my side, that for some people there is time for a variety of individual factors and disease-related factors to either try one or two new therapies or to not. And for some people, actually it becomes too risky. And I can say actually that the disease-specific factors are not really giving us that much time. So have that conversation, and definitely wouldn't postpone the conversation with the surgeon.
Okay, thank you. We did touch on it a little bit earlier on, personalised medicine. So do we see a future for this going forward? Is this going to be how potential new treatments beyond what we're looking at currently going towards, seeing as there's a lot of specific cells that we're targeting in medication? Are we going to be able to personalise medications to individuals with different, types of IBD?
Yeah, I'll take that one. And I think that absolutely has to be our goal, right? If we're not talking about it, we're doing our patients a disservice. It's a slightly Marmite term, personalised medicine, because there are people out there who say it's a term of arrogance, that it implies a level of understanding that we don't currently have. And the truth is that we're definitely not yet at a stage where we can do a test that will tell us with complete clarity whether or not the treatment we're about to prescribe will work for a given patient. And yet the reality is that every single gastroenterologist who is seeing and treating patients with IBD will be doing their level best to draw upon whatever sources of information they have to try and do exactly what Charlie alluded to, which is to think about the right treatment for the right drug and the right patient at the right time, which is why, algorithms can never substitute for a clinical consultation, because the reality is there is so much nuance that we're already drawing upon. Ultimately, every patient should come out of the clinical encounter with a therapy plan that is somewhat tailored to them. And I know that's something Crohn's and Colitis UK have put an awful lot of emphasis on. It's there in the IBD standards. So I think we can and should be striving to deliver personalised medicine. We're not yet at a point where we can deliver molecularly personalised medicine, by which I mean we're choosing a treatment based solely upon a molecular classification. But by heck, is there a lot of work going into that, and actually some really, really interesting results coming out of that. I think if I can just say one more point, one of the big shifts we've seen when it comes to molecular stratification is that what used to happen is pharmaceutical industry develop drugs for this whole area of unmet need. There were very few effective treatments, so let's develop drugs that as a whole can work for patients with IBD. And then only after those development programs did academics start to ask questions about, well, can we identify molecular predictors? As the space has got increasingly crowded, as there are more and more therapeutics coming through, what we're seeing is that already in drug development, there's a lot of emphasis and a lot of effort going into identifying those molecular predictors. So already drugs are coming to late stage development, coming to market with a lot of molecular information available. And that means effectively that the academics, the clinical community have a bit of a head start, and that hopefully we can already begin to understand a lot about what these drugs are able to do and also what they're not able to do based upon the information that's obtained during their development programs.
And that's a really interesting point about what a drug can't do for you. I think that's a really important probably point to raise, is that whilst we pin hopes on new treatments working for us as patients, we also probably need to understand that you know, every medication that comes out won't fix everything. You know, there's more to IBD than just the medication. So do you think that future treatments will also encourage a more holistic view of how we treat IBD?
I really hope so, Louise. I think there's a huge interest now, and it's incredibly heartening to see it. Actually, it's coming from the pharmaceutical industry a little bit as well now, that, you know, you can treat inflammation, and then still there are things left like fatigue or pain or just worrying about the unpredictability of what's around the corner. And of course, we can do what we can now, you know, today about trying to deal with those things. There aren't the best tools in the world to deal with some of these things, but there are still tools to deal with them. And that last slide that I showed with the circles on, I think is, you know, it's trying to make the point about exactly these aspects of IBD and what IBD stands for. You know, again, CCUK has done a lot of work here, but trying to link up psychological services a bit more is a real, you know, passion I think that Tim, Charlie and I share in the UK, trying to get better support and care for these particular aspects is really, really important. Fatigue is a tricky one. It's a very difficult one because it's a very difficult symptom. But again, there's a lot of research going on, just to give a real note of optimism, a massive amount of research going on in IBD fatigue. And maybe the pandemic, one of its legacies is going to be there's going to be a lot of work generally in fatigue, because people are now seeing what post-viral fatigue feels like. So some of the pathways might be common pathways. So I think some of these symptoms, again, we might have to think of them slightly separately, because they don't completely, they are dissociated a bit sometimes from inflammation. They're there when the disease is in remission, but they still need thinking about and dealing with. There might be drug targets in the future, there might be psychological approaches, which we can do now, but I think it's probably a both approach needed.
Yeah, I agree with all of that, Elsa, completely. There is a huge amount that we can do already, especially if we are faced with in the clinic someone who has had an early prompt or a new diagnosis that comes to us. Because when inflammatory bowel disease is early, if we can, as accurately and completely as possible, target and treat the inflammation, then hopefully we can minimize or offset any of the sort of future burden of the illness that can come, not just from the inflammation over time, but from the bowel damage that causes pain and these other factors that are associated over time, like fatigue, and also some of the sort of bigger psychosocial implications, as Elsa points out. So having a greater choice with our medicines, with different ways of delivering them that's more patient friendly, I think does allow us to be more holistic. But I think more than this, moving forwards, what I see as a near to midterm future is a layer where we've got these drug therapies that are working effectively, hopefully with minimum off-target effects, on top of which we understand not just the psychological piece and how to intervene to help that, but also a layer that's targeting dietary strategies to help patients eat in the way that's best for them, and that might be very individualized. There may also be some kind of specific microbiome targeting strategy that's either interlinked or separate from the diet. So you've almost got this very personalized collection of different bits that we put together. And as Tim says, a sort of personalized approach might be very, very personalized with time, but I see it as drug therapy plus psychological therapy plus dietary therapy and microbiome therapy all together.
That sounds very ambitious, but I like it. It feels like you're getting the whole picture about what we are thinking as patients. that it's not just how our bowel reacts. I mean, we always, you know, as an online community, we always talk about it goes beyond the gut. And that's the hardest part to explain to some people at some times. So I really appreciate the fact that you're going above and beyond, literally, to expand what you think may be going on future-wise treatments. So thank you for that one. I've had a question.
Another word about that, because of course,
yeah, go ahead. Yeah.
Joint symptoms or problems with skin or problems with the eyes. I think, you know, again, sometimes people forget to mention those things to us as the gastroenterologists. So, you know, they can be part of IBD. So if they don't get mentioned, do ask, because we can try and do something to get into the right hands, whether it be a rheumatologist or whatever, to try and help. And sometimes it affects the choice of drug as well. So just making sure you do mention to your gastroenterologist about things that you might not think are related, but all of those things absolutely can be. So ask away.
Yeah, that's definitely a good point. Definitely a good point. So I've had a question in the comments. So in regards to personalised medicine, I'm hoping that it gives people the right treatment at the right time. Could the fecal calprotectin tests be used to monitor levels of inflammation even beyond what we're already looking at, so rather than waiting for symptoms to arise?
Charlie, it's got your name written all over it.
Yeah, it has, hasn't it?
The short answer is yes, we're doing it already. I think there are still a few pockets across the UK where it's perhaps not being used as much as it can or should be. Calprotectin is an inexpensive test now. It's not, as Elsa said earlier, necessarily a very patient-friendly test, but it is phenomenally helpful. It's now embedded into our clinical practice, where people are in a risky situation, shall we say, either with active disease or starting a new drug. Checking it every couple of months can be really helpful. And it's increasingly or really firmly now embedded as a target within clinical trials of all these new drugs, so we can get better ideas about that. And it is now available in home testing version, so patients can use it at home. None of those point of care tests are perfect. They're all a bit fiddly and they're all quite a bit more expensive. But there should be, for every person with inflammatory bowel disease in the UK, the ability to get their fecal calprotectin checked. I don't think I speak out of turn when I say that. And I would really encourage patients living with Crohn's disease and ulcerative colitis to get their calprotectin checked, if to suggest it or indeed request it from their doctor, from their GP even, which can be very straightforwardly done. Hopefully have a system to get the result back. And very, very broadly, although there's a huge range here, if your level is less than 250, you're broadly going to be sitting within target. That's going to be hugely individualized. But if you as an individual person living with Crohn's disease or ulcerative colitis get your calprotectin checked and it's over 250, then that would prompt you to phone your nurse helpline, get in touch with the IBD system. If you can't, phone your GP and get referred back in or whatever. I really would encourage patients to be empowered to start to do that. I think it's really helpful.
Great, thank you. So we're heading into the last sort of 5-ish minutes of the chat. So I've got some quick fire questions for you. So if you each could individually sort of just respond within probably under a minute, that'd be great. So are there any new treatments on the horizon for microscopic colitis? Who wants to go first? Charlie, go.
No. Short answer is, so microscopic colitis is quite different from Crohn's disease and ulcerative colitis. It can be hugely debilitating. It's not usually progressive. Most people will thankfully respond to a local steroid that stays within the gut called budesonide. There is a newish formulation of that is being used that works pretty well. Rarely, and it's really pretty rarely, we repurpose some of the drugs that we used to treat Crohn's disease and ulcerative colitis to treat microscopic colitis. But thankfully, the vast majority of the time, it's not necessary.
Great. Elsa, are any of these new treatments going to be used in pediatric care, or is it just adult care at the moment?
They'll all filter down. It's one of the greatest frustrations, I think, to us that particularly, those of us who do transition clinics, it's just not as easy to get some of these, but they are going to filter down. Right. And I think I would sincerely hope, and again, with a note of optimism, that the timelines to getting to that end are going to get shorter, I would hope.
At least 2 of the new therapies that are coming in the next 12 months will actually have their license from 16 and up, and previously it had been 18 and up. So there's already a big improvement here, because many of us will look after that transition age. So that's fantastic. So it is.
I think behind the scenes there's a lot of discussion going on with regulators about ways that we can. The ethics of clinical trials in younger people are complex, but there's also every bit as important, if not more important, that we develop new treatments in this area. So I think regulators get it, and there are some interesting and novel approaches to designing trials so that we obviously no one wants to bring unsafe treatments or rush treatments through, but at the same time waiting 15 years to understand that a drug that works in adults can also be used in kids, that's not on, right? So I think those conversations are happening, and we're already seeing promise there.
Great. And just a final question, what about the future of stem cell therapy or fecal transplants for treating IBD? How do you feel about those, Tim?
Gosh, stem cells, there's so much promise, so much discussion, and there are so stem cells is not a single therapy. There are lots of different types of stem cells. Some of those, there are already licensed stem cell therapies available for perianal Crohn's in Europe, for example. So we're already seeing some forms of stem cell therapy in clinic. It's very hard to generalize, but these are complex treatments. They're challenging to run studies in, and generally speaking, they're being reserved for very, very refractory or indeed children actually with very aggressive IBD. Fecal transplants. Look, fecal transplant, I think, is undoubtedly showing a lot of promise. We've seen a lot of evidence that they work, particularly for patients with ulcerative colitis. I see, personally, I've been interested in Charlie Nelson's views, I see fecal transplants as kind of a placeholder telling us where the treatments of the future are going to be. I don't think 5 years, 10 years from now, we're going to be swishing poo samples up people's bottoms to try and improve there. But I absolutely think we're going to be intervening to try and modify the guts, the bugs that live in their guts, hopefully in more elegant ways. And we're already seeing lots of work done with freeze-dried encapsulated spores of bugs, and the ability to culture some of these bugs outside of in the laboratory, so we can get standardized, safe, palatable, acceptable treatments. That's definitely going to be the way forwards, probably as an adjunct rather than instead of the treatments we're already delivering.
Great, thank you. So probably to round up, I've got a very, very final question. How do patients get onto a trial for new treatments? Is there any particular way to do this?
So the easiest thing is to ask their consultant if they're running any of the trials. Crohn's and colitis, and Ruth might want to say something. You've got a lot of details on your website about trials and where they're going on. So that's another information zone. But asking your consultant what trials are going on is for sure the easiest way.
Great. Lovely. Well, thank you very much for answering all those great questions. I'm going to hand back to Ruth. Yeah.
Thanks, everyone. Yes, in terms of getting involved in research, we've got lots of information on our website, and we've got a newsletter as well that you can sign up to. So be fantastic. We'll post those links up in the chat. I'm just going to go to Charlie for one final comment before I wrap up.
I just want to leave people with a real sort of sense of an optimistic note here. I'm sort of really conscious that for people with IBD, life can be very, very difficult. The last 2 years have been very challenging for many, many people. I do really sense that there is a huge amount of really positive activity happening in all those key sectors, from us as clinicians and academics, in industry, and with the work that Crohn's and Colitis UK are doing. It is incredible the number of new therapies that are coming. They are coming quite soon, and some of these drugs look very, very promising indeed. They won't give us all of the answers, but I'm very optimistic about what the next 1 to 2 to 5 years holds, and beyond that, super optimistic about what can be achieved. So I think that was just wants to leave everyone with that note, Ruth and Louise.
Thank you.
That's great. Thank you. That's a really lovely, encouraging and optimistic note to end on. So Fantastic. Thank you so much, everyone, for joining us tonight. We hope that everyone has found this webinar useful. There's more information on our website. And just to add that if this Facebook Live has affected you in any way, please remember that you can contact the Samaritans. You may also want to contact your GP or your IBD team with any questions that have arisen from tonight. So we're recording this broadcast. It will stay on our Facebook page, and we'll also post it up on our YouTube account. And we've got more Facebook Lives coming this year. So our next one, topic which I know will get loads of questions, really interesting, and it's come up tonight, is food, diet and IBD. So look out for that one as our next Facebook Live. But just to say a final thank you so much, Louise, for being our co-chair and asking the questions and sharing some of your experiences as well, which I think is really fantastic and brings it all to life for everyone. Thank you so much, Charlie, Elsa and Tim as well, for giving up your time this evening. We're really, really grateful, and it's really fantastic and encouraging to hear about all these new treatments and possibilities that are on the horizon. So thank you very much, everyone, and good night.